welcome to Menopause Rescue. I'm Dr. Polly Watson. Midlife women are often caught up in a sea of symptoms. Too often, they're overwhelmed by the lack of support from mainstream healthcare. They're inundated with so-called experts who are selling solutions which may lack credibility. I'm a Menopause Society certified gynecologist with both traditional and functional medicine training. I'm here to guide you through this transition and help you decipher the facts from the fads. Armed with credible information, I hope you are empowered to rescue and restore your health, making the second half of your life your best. Welcome to Menopause Rescue. I'm your host, Dr. Polly Watson, and I am so delighted to be with Dr. Blair Watson, who is not related to me, but I would take her as a sister any minute of the day. Blair Watson is a doctor of physical therapy, and she did her training at UNC Chapel Hill and then did her residency at Georgetown University Hospital. And the cool thing about Blair, there are a lot of cool things about Blair, but one of the great cool things about Blair is that she's trained in orthopedic physical therapy, functional manual therapy, and in pelvic floor physical therapy. So I love that she has such a broad area of expertise. And we're so excited to have you, Blair. And then you're the owner and founder of Blair Watson Physical Therapy in Cary, North Carolina, correct?
That's right.
Fantastic. Well, thanks for being here.
Thanks for having me. I'm super excited to talk to you today.
I send lots of patients to Blair for sexual pain, and we wanted to kind of talk about that today. I will say one of my favorite reasons to refer patients to Blair is because she's also an exerciser, and sometimes those of us that are at midlife that are having hormonal changes that can affect sexual pain, we're also really trying to do what we're supposed to be doing and go to the gym and lift heavy shit. And so if we've got some imbalances going on there, that can also show up as pelvic floor hypertonus, and that can hurt with sex. And so I love that you have all this academic training, but also in your real life, you are also practicing what we preach and exercising and lifting heavy shit. So
That's right. I love to lift heavy. And one of my favorite hobbies is just some competitive Olympic weightlifting. So I definitely am a fan of exercise.
that is so cool and so important for our bones. So today we're going to talk about sexual pain, and maybe we could just sort of dive right in, because I think that people in your space are so unbelievably underutilized for this problem. So people often show up to me and then they say, "Oh, just give me little hormones, I'll be fine." And I say, "Well, I'm going to give you a little bit of hormones, and I might give you a lot bit of hormones, but if there's a musculoskeletal problem, we also need to address that. If there's a dermatologic problem, we also need to address that." And that's the musculoskeletal problem is where you come in, and where I see so many women that have struggled for so long and they've gone to multiple different healthcare providers, and no one's done a correct pelvic exam, and no one's identified that there's a musculoskeletal problem, an origin to the problem.
Absolutely.
So a lot of women, when I bring up, "I've got this great woman, I promise she's not related to me, she's going to help you with pelvic floor PT," they freak out. They're like, "You're going to do what? You're going to send me where?" So let's just break it down. We are going to make this much less scary for people. So I walk in your office and I say, "Blair, I have sexual pain. What's going to happen?"
So the first thing that happens when you first meet with a pelvic floor physical therapist is a pretty thorough talk through as to what is bothering you and why and where. We do a lot of talking in the first part because a lot of times people will come in and say, "Okay, I have pain with sex." I have lots of follow-up questions about the location and the nature and when that is occurring. When did it start? Because first I want to get a better sense of what could be driving this pain. And the patients that you send to me, it's awesome because I know that they already have had a medical provider talk to them and address maybe some of the medical driven causes like dermatological issues, if there's any infection, hormone changes. That's great. A lot of times too, people are coming to me not having talked to any medical provider yet and saying I have pain with sex. So I need to do a thorough medical history to get a better sense as to what's driving that pain.
Mhm.
Um, so the first thing I'll ask about is the location of pain for women or persons with a vagina vulva having pain with sex. I want to know if the pain is more on the external tissues, like in the vulvar area, um, versus are they having pain with any kind of penetration in the initial entrance of the vagina, which we call the introitus, like the actual tissue that's right around the very opening of the vagina, versus sometimes people are having pain with deep penetration. And when we're talking about penetration, that can be anything. We're talking
Right.
about a finger, a toy, a penis, whatever.
Right.
Um, so it really gives me a lot of clues once we determine when and where are you having the pain. And that helps kind of guide me as to what kind of treatments are helpful, especially from a PT and musculoskeletal component.
I love that you're kind of breaking this down, and I just kind of want to pause because I feel like women don't use or don't maybe know or they're not comfortable with the language to use the right words to describe what part of their body. So much of the time, anything in the genital area is referred to as the vagina. And
Right.
so it we don't need to give you a schooling in like what the right word is or make you use words you're not comfortable with. But it can be really helpful to distinguish this is an outside problem, this is a near inside problem. This is a deep inside problem. But
Exactly.
just distinguishing outside versus inside, because I will seriously have spent 20 minutes with someone and I'm just scratching my head and they keep saying vagina. And I think they mean their vagina, but they don't know the word for vulva and
Hmm.
the external labia minora, labia majora, the perineum, that external tissue. And I'm like so confused. And then I'm finally like, oh, we're using different words for this. So maybe just to make sure when you're meeting with a healthcare provider, you don't have to use our fancy words outside, near inside, deep inside.
Absolutely. I also will very frequently use visuals. So I have models, I have pictures, and I'll often, here's an example of my pelvic model. I will bring it out when we're talking to each other and ask the patient to point to like, where is it? Because you're right. I think there can be lots of anatomical different knowledge of what the terms are and where they're feeling it. Um, and also, this is an area of our body that we don't commonly see in a mirror unless we are very intentional about looking at it. So
Yes.
it is often, I find, kind of this just nebulous part of women's bodies. So if we can look at a model or a picture or have someone point to like, oh, I think this is where I'm feeling it,
Hmm.
very
Hmm.
helpful.
Yeah. And
Yeah.
so I just want to kind of reiterate something you just sort of outlined. So when I talk with patients and I say, wow, I just did your pelvic exam and it when you feel a muscle, like you can see, look at my bicep, right?
Look at our
I
bicep.
don't have bicep, right? It's firm muscle. But when you're feeling a relaxed muscle, you can tell there's muscle tissue there, but it's not taut, right? So when I'm doing a pelvic exam and it feels like I'm going over speed bump after speed bump, or kind of we use like the term guitar string or violin
Mhm.
string, you're plucking strings of tight muscles, I'll be like, wow, this patient needs a pelvic floor PT. Um, they get a little like, what are you gonna do? Huh? What are you gonna do? I just want to reiterate, Blair is probably spending what 20 or 30 minutes. No one's clothes are even off yet. You're having a
Nope.
conversation, right?
That's right. That's
And
right.
so you're looking at a model, you're having a conversation. Your resources are so helpful for so many people. We want to lower that anxiety barrier to access these resources. So far, all we're talking about is a conversation. This is not scary.
That's right. Yes, and thank you for that acknowledgement. I say in pelvic health PT and really in all medical care, like the patient right, has decision and choice and consent over what is done at all times. And that is definitely the case in pelvic floor PT.
Mhm.
So after we've spent time talking with the client or the patient about what's going on, then I say to them, a colleague, a great pelvic floor physical therapist, Christina Holland out in Colorado, came up with this. And I love this analogy that you can present a menu of options as to what we can do and how we can proceed with treatment. So, first on the menu is evaluating with all clothes on. So we're looking at how is your abdomen moving, how's your spine moving, how's your hips moving, all of the things that can contribute to some of that flexibility of the muscle system that's next to the pelvic floor.
Mhm.
The next kind of available menu item is to look and observe and palpate on the external tissues of the perineum. So that is where, and if the patient chooses to do that, I step out of the room. I set up my comfortable exam table. We say there are no stirrups in pelvic floor PT, so it's just a regular massage treatment table. I step out of the room. The patient then takes off clothes from waist down and covers themselves completely with a sheet. I come back in the room when they're ready, and then we go from there. I am explaining everything that I'm doing along the way, and I'm asking for consent and feedback at all times. So oftentimes patients sometimes will be like, gosh, you're really like taking your time or being slow or asking a lot. And that's to ensure that the patient is ready and consenting to what comes next so that it takes down some of that fear that can sometimes occur. So,
Absolutely. And
yeah.
I just want to plug you guys, like as a gynecologist, we have not always done a great job with what you're describing, right? And so being a gynecologist, but also being a pelvic floor PT patient, and I've seen tons of you guys, I'll just say from the patient end of things, pelvic floor PTs have been way slower, way more gentle, way easier than any pap smear I've ever had. And like, so
Yeah, and I say the PTs, we do have the gift of time in medicine that other providers do not. So I spend an hour to an hour and 15 minutes with my patient, and I know that with physicians that time frame is not always possible. So we do have the gift of time in PT so that I can really make sure that the patient knows exactly what's going on at all times. So yeah, so I wear gloves and kind of that, again, the way that I assess the external tissues is I will use my hands and just kind of observe, what do the external tissues look like? Does it look like there's irritation? Does it look like there's dryness? And again, if they have not seen a medical provider and they are perimenopausal or menopausal, and I'm observing dry tissue, then I'm getting also our physician friends on board in the treatment plan of treating that.
mhm.
Um, then, if we want to do what's called an internal pelvic floor muscle assessment, I will use one gloved finger, lubrication on my finger, and I will place my finger right at the very entrance of the vaginal opening. And that is where we start to assess the tightness, the hydration, the neural feedback of what does that tissue react to being palpated. It is very gentle. And again, I'm in contact with the patient the whole time of like, okay, with my finger resting here, is that burning? Does that feel like it's tearing? Does that feel like it's buzzing? And then we go from there. And then I will assess further into the vaginal canal and in the pelvic floor deep musculature. I can feel, is there muscle tension? Is there guarding? Is there tension when there shouldn't be? And again, we can make some, it's kind of like we are trying to find the tissue that's almost simulating what are you feeling during penetration or sexual encounters that is um, reproducing that pain. So if we find, okay, on the left side in the deep pelvic floor muscles, I'm touching a muscle and that's reproducing your pain, that throbbing that people sometimes will experience, then that gives us a clue as to, okay, we've found a tissue that is tight and tender, and now we know this is going to direct our treatment there.
Yeah, I've definitely had patients who are like, "Oh, that's the spot, right? That's
Yeah.
exactly what I'm experiencing. And I love that you're describing lots of different sensations that people can experience. So I think sometimes when we maybe pull a muscle or we work hard at the gym, muscle tightness in the pelvic floor can present as burning. It can
Mm.
present as throbbing. It's not just an ache. And it can feel like it's tearing. And so, we're also sort of thinking about, is there almost a neuropathy here? Just like if someone has really tight brachial plexus in here, they may get numbness and tingling going down their arm. If their pelvic floor muscles are super, super tight, the pudendal nerve and all those nerves, those branches coming down, are kind of getting compressed.
Compressed.
And
Yes.
so, just like up here, where it gets kind of numb and tingly and buzzy and it doesn't feel good and it might hurt, same thing. And so I love that you used all those different descriptors, because someone might think, well, it doesn't hurt like a Charlie horse hurts, or it doesn't hurt like a sore muscle hurts. It's this burning feeling. That must not be it. And that's not necessarily the case.
Yes. And to generalize and simplify some patterns that I think we commonly see, that initial penetration pain tends to be more of a searing, burning, tearing hypersensitivity
Hmm.
versus pain that's experienced with deep penetration is often described as like deep ache, throb, which is almost more in the kind of muscular category versus some of that hypersensitive and more maybe fragile tissue at the entrance of the vagina. So yeah,
Right.
so that's why the patient report and description of what's happening in their bodies is so important. And again, I know sometimes it feels funny and strange to talk to a new medical provider about that, but also knowing that, like, again, this is our area of expertise. We talk about this all the time. And whatever the patient wants to share is also within their parameters. So I never want to feel like I'm pressing for information. So whatever information is offered, that's what we use to help make clinical decisions.
Right. But I would say that, and obviously we're going to be very respectful about what someone wants to share or doesn't want to share. When when you were kind of thinking about that initial interview, if someone felt safe disclosing this kind of position when I'm on top, and if I'm having penis and vagina sex, or I'm having a toy put in at this angle, that's what causes the pain. Sometimes that can really point you in a direction. Just, and people may not be comfortable sharing that, but if they are, it can like really narrow things down quickly.
Absolutely. And then on the flip side of that, PTs, once we derive a lot of this information through your report and through our physical exam, then we can help offer ideas on treatment and strategies for you to utilize at home to make sex more enjoyable and comfortable, like offering advice on positions.
Right.
So, for instance, if someone is having difficulty with deep penetration, then I may guide them or steer them to try positions like side lying, um, or on the person receiving on their back, which lets the muscles of the pelvic floor relax a little bit more. Versus a position where the receiving partner is on their hands and knees, that can often allow for deeper penetration. So,
Mhm.
if we know that that is one of the triggering factors to your pain, we may temporarily steer clear of that position while we're trying to get a better handle on what can help with that pain.
Right.
Yeah,
And that can be
absolutely.
so practical and like,
Yes, yeah, yes. Sometimes it is very, again, simple changes that can make a big difference.
so there was a patient I saw yesterday, and she looked at me like I had three heads when I was like, okay, yes, there's some hormonal changes. The skin, I guess, if people are looking at their genitals and they sort of separate their labia minora and they sort of see that vaginal opening, the inside of your vagina should look pink and lush like the inside of your mouth. And if the inside of your vagina is starting to look like whiter or paler, regardless of what your skin tone is, like less pink and lush, that's a sign that it's not getting up as much blood flow. It's not getting as much estrogen typically, but we also have androgen receptors there. And so we identified that, but then we also identified one spot on her left-hand side, kind of anteriorly, and we're like, oh, okay, that's the spot. So when I talked about pelvic floor PT, she was like, well, how did this happen? Why did this happen? And I thought, well, that's such a great question. And it's not like we can go back in this person's life and say, you fell down the stairs when you were 10 and had your coccyx was tilted forward and that was part of it. Or maybe someone had an unwanted sexual encounter in high school and that was part of it. Or so let's kind of talk about, how does this pelvic floor overactivation happen? Because I
Mhm.
think sometimes we want to be really clear that we're not blaming the patient for having this, right?
No.
I kind of tell them, like, no one says, I don't want to have a migraine by 4 o'clock. So I'm going to tense and tense and tense and tense. And by 4 o'clock, all this is so tight that it'll trigger a migraine. No one does that, right? No one's doing that
Right.
consciously in their pelvis. But maybe it would be helpful to talk about what are some things that can trigger pelvic floor hypertonicity. The muscles are too tight, and then that can cause pain.
If the muscles are too tight. Okay, so you're right. That can be a host of things. One, if there's any kind of, I say like physical trauma, just like you talked about, fall down the stairs at age 10, the coccyx is in a different position. The pelvic floor muscles attach to the tailbone. So it might be that the position of your tailbone may place one side of the pelvic floor, those muscles under tension compared to the other. Um, I am always asking about history of childbirth. It might have been that something occurred during a vaginal delivery on that left side, if there was any kind of tearing or trauma to that tissue. There also is pain with sex with C-sections, or any abdominal or lumbar surgery. All of those tissues that are above pelvic floor are connected to the pelvis. So if there's any tension or tightness around, it can affect how flexible, how hydrated, how are those pelvic floor muscles moving.
Mm-hmm.
And then sometimes, Dr. Watson, sometimes patients are like, why that side? And sometimes I don't know. Sometimes it just is. It might be that your hip is a little bit arthritic on that side. Why that happened on that hip, I don't know. Um, so yeah, so we try and find some clues and pearls to help kind of give some reasoning, because oftentimes I find patients feel more safe, their nervous system feels safe when there is a reason for things. So we do our best, and sometimes we don't know the full picture.
Well, I think I just want to add, like, type A girls like myself that maybe are a little wound up tighter than a banjo string, right? I clench my jaw. I could make this an Olympic sport, right? So the same fascial connection when I'm tightening my jaw is I may not breathe really great diaphragmatically. I'm working on it, right? But then
Mhm.
I'm also holding my pelvis too tight, right? And so
Yes.
that's a pattern that we see where, for lack of a better term, this is where I hold stress in my body. It's
Mhm.
not intentional. I would love to not grind my teeth. I'm asleep when I'm doing it. I don't know how not to do it, right? I
Sure.
take magnesium, I meditate, I go to yoga. I'm still wound up tighter than a banjo string. So this is what I got, right?
Yeah.
And then I think the other thing that's been really true for me is, and something that I do a lot in clinic is, if you're kind of trying to assess, you've been talking about these other muscles, but like your six pack, haha, if I had one of those, right? Lateral and deeper to that is your psoas muscle. So maybe you can see that my psoas is really pretty tight. This is your hip flexor, right? It goes from your
Mhm.
10th rib to the front of your femur. Oftentimes that's really tight in women who have a tight pelvic floor. And and in my case, it's because I haven't done a great job about learning to activate my glutes. So the front of my body takes over, my pelvic floor takes over for a muscle weakness, right? And so I love, that's one of the reasons why I love sending patients to you, because when we're trying to get women back to the gym and they're having sexual pain, we want someone who's got pelvic floor training, orthopedic training, some sports training so that we can say, okay, well, then we probably need to look at your squat and your lunge and your deadlift to make sure that you're doing those exercises correctly so that you're not undoing what we're doing in PT. Does that make sense?
Absolutely. Absolutely. And I would say, oftentimes sexual pain is driven from just what you said, a hypertonic or too tight pelvic floor musculature. So when we want during sexual intercourse, we want those muscles to be flexible, well hydrated, so that they can receive blood flow, because blood flow drives arousal. We want blood to be able to go into those muscles so they are stretchy, expandable, relaxed. We generally don't want muscles that are really tight. It blocks the blood flow from coming in, and it doesn't allow for easy penetration or for something to come into those muscles. So you're right. There's a lot of strategies that we will work on in pelvic floor PT to make sure that those muscles know how to, strategies to help them let go, stretch, lengthen. So some examples of that, sometimes we will use what's called a pelvic wand. So everyone knows what a foam roller is. So a lot of my runners will use a foam roller to help stretch and expand the hip flexors, the hamstrings, the quads. We're using a tool to apply pressure to get tissue to stretch. Well, a pelvic wand is a foam roller for your pelvic floor. For those that can't see on the screen or listening to audio, it is essentially like a little snake-like wand that can be used to insert internally into the vagina, and it helps to gently massage tight tissue, which then helps with blood flow and helps get your brain more used to, like, oh, that's the area of my pain. It helps to desensitize and stretch that area.
Right. And the wand that you have is the intimate rose wand, correct?
That's correct. That's
Which
correct.
which people could buy online on their own. And
Mhm.
if you're, I think the best case scenario is here, someone takes this one with them to PT so they can kind of learn how to use it. But just to sort of emphasize, the amount of pressure you're putting on your tissues is like you're testing if a peach is ripe. You are not going for gold. Well, this is not the lacrosse ball in your trapezius muscle, right? This is
That's right.
peach or tomato ripe, real gently.
Yes. And that's why, again, people, this is over the counter. You can order this. But I think it's best used under the guidance of like someone showing you, here's an optimal way to use it.
Right.
So we can use tools like this to help teach those muscles to expand and stretch. And then also what's a really important part is an exercise driven way to help those muscles expand and stretch. That is through a lot of breathing strategies. So teaching people how to breathe diaphragmatically, which sends a signal to the pelvic floor muscles to relax and stretch. And then I utilize a lot of yoga type stretching mobility exercises, which are beneficial to, one, down regulate the nervous system, help people kind of experience that calm, and then also to stretch the tissues. And then just like you were talking about, oftentimes we will find an imbalance of muscles somewhere. So for someone that is, let's say, unfortunately in this country, women have been given the message that we need to be smaller in our waist area. So that I see all the time that people are in a chronic abdominal gripping pattern. They walk around and they've been told, tighten your core or hold your core, or if you don't have your core activated, everything's going to fall apart. So they get in this mechanism of having a chronic clench through their abdomen. The abdomen is right next door to the pelvis and the pelvic floor muscles. So if the abdomen is chronically activated or tight, the pelvic floor is often right next to it and doing the same pattern. So a lot of times I'm just trying to teach people, can you let your belly sag and just be gentle and let it go? Which is a lot harder than people would expect because, again, we've been kind of told to clench and be smaller there. So
Right.
So those are some of the exercise and movement-based strategies that PTs will often use.
I just wanted to go back to one thing you said, because so many women at midlife are struggling with sexual desire, arousal. I'm kind of, things are getting tingly and exciting, and then orgasmic function. Like, there are lots of problems with sexual dysfunction. And you were talking about how the muscles really need to relax to get more blood flow. But I just kind of wanted to circle back around to orgasmic function, because when someone's pelvic floor, if we think about an orgasm as a giant contraction, if the muscles are 85% contracted, there's not a lot of way to go there. And so sometimes women will complain, I have this little squeak of an orgasm when I used to have this big mama orgasm, right? So um, I'm just such an advocate for, we don't just want to have pain free sex. We want to have sex that's worth freaking having, right?
Absolutely.
And
Yes.
so part of healing this is not only getting out of pain, but getting those muscles so that you can get more blood flow, you can get better nervous function, and that you can get your big mama orgasm back, that there's some place to go. But if everything is tight like this, there's just not a lot of give in the system.
That's right. And again, with our extended time with a patient, we talk a lot about this, and we develop an individualized strategy for each person on how do we get you there. There is a lot of tools and patterns that can be done leading up to intimacy that can help you have a more pleasurable experience. I spend a lot of times talking to patients about um, their pattern with their partners and what happens with sex for you. Is it planned? Is it spontaneous? What is your stress level like? Is it quick? Is there foreplay? Because we know for people who, if you have safety in your body, if you feel connected and calm in your nervous system, if you have warm, flexible tissues, if there is less stress, if there is foreplay that helps with that blood flow, you are much more likely to have a pleasurable experience that could involve orgasm as well.
Mm-hmm.
So I often, and we kind of develop a game plan of like, okay, this might be where you need to schedule when you're going to have intimacy, whether it's solo or with a partner, but it's scheduled so that you know beforehand. Is it helpful for you to have the kids and the dog out of the house for the evening? Is it good that you plan this maybe on a weekend morning when there's less stress, less activity going on? Do you need a bath beforehand just to take your nervous system down? Do you want to use a vibrator on yourself 10 minutes before any kind of partner interaction? Do you need to have a conversation with your partner about what you like and what feels good and what is going to be helpful? All of those things are appropriate to talk about with a pelvic floor therapist to develop a game plan for what works best with you. I say it's no different in how we work with athletes. If they need to perform well on a marathon, then we make a game plan for how is that going to get you to your goals of what you want to do.
Well, I love that you use the athlete, because a lot of times when women are having sexual pain, I really encourage them to work with self pleasuring before they kind of get to the Super Bowl and they involve another person in the interaction. Because sometimes when people have had a lot of painful sex or sexual trauma, it's really scary to go there again. And if they can practice and develop some confidence without having to mitigate another human being's, their whole
That's
mind,
right.
body, space, whatever, they can kind of figure this out. So
Yeah.
let's
Yeah.
practice before we go to the Super Bowl is kind of what I
Yes.
would say.
Yes. I just was talking with a patient yesterday. We've been working on a pelvic wand and she's been using it solo. And we've been talking about pain with sex. And I said, well, why don't you try 10 minutes before you have planned sexual intimacy that you use your pelvic wand for 10 minutes. And that is a way that you are warming up the tissues. You are stretching the tissues. You're giving some feedback to your brain of like, hey, there is sensation here and it's safe and fine. then leading into anything with your partner. It's just a way to warm up for the activity ahead.
Right. There is a paper on looking at libido and low libido, and that couples that exercise together, or that if, when there was exercise before sexual activity, the female part of that couple was often more receptive to intimacy right after exercise because we're out of our heads and we're into our bodies, right?
Yes.
So I love that. Like Saturday morning, go to the gym, work out, take a bath, use your wand. All right, I'm ready. It might take me a little longer than it does in the movies, but then it'll be worth it, right?
That's right. And I find too, what is helpful is patients that can acknowledge and eventually accept that bodies change and patterns change. Um, it is likely that your 10 years ago, you may not have had to do all of that prep work in
Mm-hmm.
order to enjoy sexual encounters. But the fact of the matter is that bodies change, bodies age, and that we just take sometimes some more care and logistics in order to enjoy and be aroused. So sometimes, of course, change is hard, and mental resistance to change is a real thing. But once we can kind of get through, like, okay, this is how it is now, and I just have different and new strategies that my body needs.
I love that reframe. And I just sort of feel like at midlife, we have to be so much more intentional about all of the aspects of our health. I have to be so much more protective of my sleep. I have to be so much more protective of my mental health and what I take on. I have to, I, I got to go to the gym, right? And I got to
Yeah.
eat and fuel so that I can power those workouts at the gym. Like the whole rest of the care and keep food and watering of this midlife body is requiring more time, attention, money, and energy than it did 15 years ago. So sex is kind of the same way. But like many things that I'm really feeling like at midlife is that I get it now. Like, I don't know. I just kind of want to wave the flag for midlife sex because I'm not wiping bottoms. I don't have this tiny little window while I've got a 3-year-old and a 5-year-old. I mean, it's a different season, but I think it's a great season.
Yes. And I've heard your message on that very strongly throughout the years, that there's so much inundation with the fear and the grief surrounding midlife. But I love your reframe of, like, it can be a tremendously empowering part of our life. And this is the same. That, yes, I find that the perimenopausal and menopausal women that I'm treating, you oftentimes there's more of a connection with your body in general, and more of an acceptance of, like, this, look at this body that is doing so much, is so strong, and letting go of some of the older messages that yeah, it's just it's a better embodiment, and that of course will impact your sexual experience.
Yes, yes. This has just been so fun, and
Yeah.
I hope people walk away from this like, okay, number one, if a healthcare provider is working with you and says there's nothing else to offer you about your sexual pain, please do not take that. You need to keep looking. There are lots of solutions for sexual pain. Most people in France that have babies are routinely prescribed pelvic floor PT after childbirth. So it's a really a fallacy of our healthcare system here in the United States that this isn't just across the board standard of care. This should be across the board standard of care.
Yes.
And then, people like Blair are really cool. They're not scary. They're certainly way more gentle than any gynecologist that I've seen.
Yeah.
And we don't want to just not have we you deserve more than just pain-free sex. You deserve great sex
That is right.
or the sex you want
Absolutely.
to have, right? Whatever that means for you.
That's right. That's right. Absolutely. Absolutely.
So Blair, your practice is called Blair Watson PT and it's in Cary. Are you on social? How else can people find you?
Yes, I am active on Instagram. My Instagram handle is Blair Watson _PT. My website is also helpful. I'm starting a blog this year just to offer more free education. So that's just blairwatsonpt.com. So yes, and if you are in my community, or I love talking about this, and I love being an open resource, because I know that this can be something that people deal with in silence and isolation. So my like my hope for us all is that we can just state our truth and talk to people if there is a problem.
Well, I am so grateful to be able to send patients to you because you are such a kind, safe space.
Oh, thank you. We have a lot of fun. I mean, I try and make it as fun, funny, enjoyable as we can. It's not all
Life's too
serious.
short not to laugh about this
That's
stuff.
right. That's right. We're talking about vaginal, dilators and lube. You have to laugh.
That's right. You're the only other person who knows how everybody else has sex
But
besides me. But, it's all cool.
that's right. That's
And,
right.
if you share that, you might get some really good tips. Like sometimes a little pillow here and a little
Yeah,
twist there, and magic happens. So,
that's right.
well, thank you, Blair. This has been fun.
Thank you so much. I've really enjoyed our conversation.
Thanks for listening to Menopause Rescue. We hope you've enjoyed this podcast and it helps you create some time and space to make this the best half of your life. If you've enjoyed this content, please leave us a 5-star rating and review. This helps other listeners find this resource and rescue and restore their health. If you enjoyed this topic and want to learn more, check out our resource guide for this episode. If today's podcast resonated with you and you want to take a deeper dive, check out my educational resources. We offer basic membership, which is an archive of over 100 videos on menopausal topics ranging from bone health to libido. We add to this archive every month, so the resource becomes richer and richer over time. If you're looking for a menopause expert and live in North Carolina, take our free online class and see if we're a match for your needs. It's called Are We a Good Fit? And is a quick and easy way to learn more about our practice and what it has to offer.
Hey, this is Dr. Watson. This is just a friendly reminder that this podcast is for general information purposes only and does not constitute the practice of medicine. No doctor-patient relationship is formed, and any information you get from this podcast is considered educational only. You should make medical decisions with your healthcare provider. The content of this podcast is not intended to be a substitute for professional medical advice. Listeners should not disregard or delay in obtaining medical advice for any medical condition, and they should seek assistance from their healthcare professionals.